Hi, my name is Siddharth and my topic is ultrasound guided paravertebral block. Paravertebral block is a technique where local anesthetic is injected into the space adjacent to the vertebrae to block the spinal nerves as they emerge from the intervertebral foramen. The thoracic paravertebral space is a wedge-shaped space adjacent to the thoracic vertebral column. The boundaries of the space are, medially, the vertebral body and intervertebral foramen; anterolaterally, pleura; posteriorly, costo-transverse ligament; and laterally the internal intercostal membrane. Contents of the space include adipose tissue, anterior ramus of intercostal nerves, posterior ramus of intercostal nerves, sympathetic chain and rami communicants. Thoracic paravertebral space communicates with, medially, epidural space; laterally, intercostal space; superiorly, cervical paravertebral space; and inferiorly limited spread due to the origins of the psoas major muscle. 11 intercostal nerves, T1 T11, and 1 subcostal nerve, T12, arise from spinal cord and exit the intervertebral foramen on both sides of the vertebral column, to divide immediately into an anterior and posterior division. The posterior division divides into medial and lateral branches and supplies the muscles and skin of the posterior part of the chest. The anterior divisions initially lie between the pleura and the posterior intercostal membrane, and then continue between the innermost and inner intercostal muscles, to terminate as the anterior cutaneous branch of the thorax. A lateral branch is given off midway between the vertebral body and the sternum, approximately at the mid-axillary line, which in turn divides into anterior and posterior branches. At level of 5th to 7th thoracic vertebrae, the structures from outside to inside will be trapezius, rhomboid major, erectus spinimicil, external intercostal, internal intercostal, innermost intercostal and pleura. Superior costotransverse ligament and internal intercostal membrane continuous with each other. After puncturing superior costotransverse ligament or internal intercostal membrane, we can reach into paravertebral space. At level of 8 to 10th thoracic vertebrae, rhomboid major is replaced by thoracolumbar fascia. Rest anatomy remains same. C. Superior costotransverse ligament, our main concern for paravertebral block. Paravertebral block produces ipsilateral somatic and sympathetic nerve blockade due to a direct effect of the local anesthetic on the somatic and sympathetic nerves in the paravertebral space, extension into the intercostal space laterally, and the epidural space medially. The dermatome distribution of anesthesia following a single injection of a large volume varies, and is often unpredictable. Nevertheless, the multiple injection technique, where small volumes, 3 to 4 milliliters, of local anesthetic are injected at several contiguous thoracic levels, is preferable over single large volume injection. It can be considered for a variety of surgical procedures in conjunction with general anesthesia. It is also used, but less commonly, as a sole anesthetic technique. While it is more widely applied in providing unilateral effective intraoperative and postoperative analgesia for breast surgery and thoracic surgery, it can also be used to provide analgesia for non-surgical pain management, such as rib fractures. Beside local site infection and allergy to local anesthetics, empyema and neoplastic mass occupying paravertebral space are the main contraindications. Patient can be positioned supine, lateral or prone. Usual machine setting is high frequency linear probe in resolution mode, keeping depth 2 to 4 cm. Inline approach with dose 3 to 5 milliliters at each paravertebral space. USG probe is placed transversely over junction of transverse process and rib, just like in picture to visualized bony structures. Those are transverse process and rib. Now probe is slid downward, keeping same orientation. Rib will be replaced by hyperachoic, sliding pleura. External intercostal and internal intercostal membrane looks hyperachoic. Paravertebral space is located in between internal intercostal membrane and pleura. Usually oblique rotation at probe at this point makes pleura, internal intercostal membrane and paravertebral space more defined, sharp and widened. Needling from lateral to medial and plane approach will be more easier with oblique rotation of probe. Let's summarize. First, USG probe is placed transversely over junction of transverse process and rib. Then probe is slid downward keeping same orientation. Rib will be replaced by hyperachoic, sliding pleura. External intercostal and internal intercostal membrane looks hyperachoic. Paravertebral space is located in between internal intercostal membrane and pleura. Oblique rotation at probe at this point makes pleura, internal intercostal membrane and paravertebral space more defined, sharp and widened. In this approach, probe is placed paramedianally over the ribs, like in picture to identity trapezius, rhomboideus and pleura in between ribs. Ribs looks characteristically hyperachoic, round, oval. Pleura appears deep to rib showing comet tail appearance. Now maintaining probe position, probe is slid towards medially. Transverse process can be visualized. Transverse process looks square, deep and hyperachoic showing superior costotransverse ligament and pleura in between two transverse process. Below to superior costotransverse ligament, paravertebral space can be identified. Needle is entered from chordate to cephalad, and using in plane approach, to enter into paravertebral space. In any approaches, depression of pleura is the important sign of correct placement of needle tip into paravertebral space, while injecting local anesthetics. Let's check our real block. Bilateral symmetric anesthesia due to extensive epidural spread or unintentional intrathecal injection into a dural sleeve may occur, particularly when the needle is directed medially, or when a larger volume of local anesthetic, 25 ml, is used. Sympathetic blockage can cause hypertension and bradycardia, pneumothorax, bleeding, infection, nerve injury can be possible. Local anesthetic should be injected slowly in small aliquots. Avoid injecting forcefully at high pressure to reduce the risk of epidural spread. Aspiration for blood should always be carried out before injection of local anesthetic solution. Real-time depression of pleura during local anesthetic injection is a sign of correct placement of needle tip in the paravertebral space for single-shot block and catheter techniques. Etchogenic needles for PVB placement may further aid needle visualization. Pneumothorax is a serious complication of this block. Patients should be reminded to inhale and exhale during your injection into the paravertebral space. Breath holding during this uncomfortable procedure can lead to syncope. Thank you very much for your kind attention.